Welcome to this explainer. If you deal with medical billing or orthopedic surgical coding, you already know the deal. Arthroscopy is a fantastic advancement for patients, but it can be an absolute labyrinth for billers. Today, we're going to demystify the complex Medicare rules for arthroscopic knee surgery so you can code those multiple procedure encounters without triggering frustrating denials. We are going to decode exactly when and how to use CPT codes 29875, 29876, and 29877, following the rules to the letter. Here's a quick look at our agenda. We'll start with arthroscopy and Medicare limits, then dive into the specific rules for codes 29875, 29876, and 29877, before wrapping up with how to truly master these guidelines. All right, let's jump straight into Section 1, Arthroscopy and Medicare limits. We all know arthroscopy is incredible for patients, right? It allows surgeons to inspect the inside of a joint and make repairs with tiny incisions, meaning way less pain and a much faster outpatient recovery. But it begs a major question for us on the billing side. Why do multiple procedures done on the exact same calendar day lead to so many rejected claims? Well, because surgeons can perform multiple repairs during a single encounter, payers, and Medicare in particular, put incredibly strict limits on how many services they will actually pay for on that same day. The answer to why these denials happen lies in the NCCI, or the National Correct Coding Initiative. Think of this policy manual as your ultimate rulebook. Practices absolutely must check these code edits to stay on top of the limits. I mean, unless you enjoy the unique dread of a surprise Medicare audit. Basically, the NCCI dictates what procedures can be billed together, essentially preventing you from getting paid twice to, clean the same room, so to speak. Moving right along to Section 2, 29875, and the limited synovectomy rules. So let's talk about code 29875. This applies to a limited synovectomy. Clinically speaking, this is when the surgeon uses a motorized shaver with rotating blades to remove a synovial fold, which is also known as a plica. The absolutely crucial point you need to remember for this code revolves around these separate procedure rules in the CPT manual. You can only report 29875 when it is the completely solitary procedure performed during that encounter. Period. From an NCCI perspective, you are only allowed to bill this separately if you're performing it on the opposite or contralateral knee. The NCCIO coding policy manual does not mince words here. They are extremely clear on this limitation, stating, and I quote, code 29875 should never be reported with another arthroscopic knee procedure on the ipsilateral knee. That is a hard never. You simply cannot bill this code just to clean up a joint alongside a more extensive procedure on the same knee. That brings us to Section 3, 29876, the major synovectomy rules. Now, code 29876 covers a major synovectomy. What makes it major? By definition, it means you are shaving synovium from two or more distinct compartments of the knee. That requirement for multiple compartments is the key distinction from the limited synovectomy we just talked about. Here is your golden rule to avoid denials with this code. You need to master compartment math. You literally cannot count a compartment towards your synovectomy total if you're already doing another procedure in that exact same space. You can't double dip. For instance, meniscectomies automatically include the synovectomy for that specific compartment. Let's actually walk through a real-world math problem for this. Step 1. Let's say you have a medial meniscectomy plus a medial, lateral, and patellofemoral synovectomy. Step 2. Because the medial synovectomy is included in the medial meniscectomy, that medial compartment gets swallowed up. You just subtract it from your count. Step 3. Count what's left. You have the lateral and patellofemoral compartments remaining. That gives you exactly the two untouched compartments required to legally report 29876 right alongside your meniscus code 29881. And this logic is exactly why the NCCI explicitly forbids billing 29876 with code 29880 on the same knee. Think about it. The knee only has 3 compartments. Code 29880 means you are performing procedures in 2 of those 3 compartments. That leaves only 1 compartment untouched. Since a major synovectomy requires 2 unused compartments, it is mathematically impossible to report those 2 codes together on the same knee without violating the rule. All right, moving into Section 4, 29877, and the Chondroplasty guidelines. Code 29877 represents chondroplasty, which is simply the debridement or shaving of knee cartilage. This involves using a motorized shaver to cut out or debride the frayed edges of articular cartilage within the joint.
The one thing you absolutely must burn into your memory for this code is the once per knee rule. You report 29877 just one time, completely regardless the number of knee compartments where it is performed. Debride one compartment, debride all three, the coding doesn't change. Also, when chondroplasty is done in conjunction with a meniscectomy, like codes 2980 or 2981, it is entirely bundled into those procedures.
Look at it this way. When chondroplasty is performed completely alone, it gets its own code, 29877. But the very second a meniscectomy is added to the encounter, that larger procedure completely swallows the chondroplasty whole. You would only report the appropriate meniscectomy code. Finally, Section 5, Mastering these knee coding rules. Here is your ultimate cheat sheet, contrasting the absolute most important limits for all three codes. For 29875, it's strictly a standalone procedure on that knee. For 29876, it requires complex compartment math. Remember to always subtract any compartments where other work is being done. And for 29877, it's a one-and-done code that just vanishes into meniscectomies. Keeping this structured logic in mind is exactly how you keep your future claims perfectly compliant. Because here's the reality. Confusing these codes, overbilling when you shouldn't, or missing a legally billable code because your compartment math was a little off can cost your practice dearly in lost revenue. So ask yourself, what happens if a simple miscalculation in your compartment math triggers a massive Medicare audit tomorrow? Use these guidelines to code with absolute precision. Thanks so much for joining me on this explainer, and I hope this clears up the confusion around arthroscopic knee coding.